Hi, my name is Claire Donahue.
Hi, my name is Maribel Gutierrez.
And this is Nate, and here's our assignment 1, assessing the microsystem. Alright, so to start, let's look at the macrosystem. So Mercy Hospital of Northwest Arkansas is part of the Mercy healthcare system. It's founded by the Sisters of Mercy in 1986, and their mission is to bring life to healing ministry of Jesus through compassionate care. The vision is to pioneer a new model of care while relentlessly working to get healthcare right. The hospital is located in Rogers, Arkansas. It's recently completed a $277 million expansion that added new beds and operating suites. Nationally, it's recognized for its high quality of care, with Leapfrog Grade A, a CMS rating of 5 stars, and recognitions as one of the top 100 hospitals. Mercy also participates in value-based care initiatives like CMS, ACO programs, helping reduce patient readmissions and complications. Looking at the microsystem, we're looking at the operating room. The operating room brings a team of surgeons, anesthesiologists, CRNAs, nurses, surgical techs, and anesthesia techs all working together to provide good surgical patient outcome, reducing complications, and also making sure that the patient have timely access to needed procedures. This also contributes to the hospital performance by driving surgical volume, improving patient satisfaction, and maintaining quality and safety metrics. Looking at the external systems and influences, the OR is shaped by the Joint Commission, CMS, and also Leapfrog to ensure safe and high quality of care to meet reimbursement. Partnership also play a big role in the OR. Mercy would work with local health networks, community providers, and educational institutions. For example, the Walton Foundation has helped Mercy expand advanced surgical services for cardiac patients. Nursing school and nursing anesthesia school provide students rotation to strengthen the workforce, especially in the OR. Overall, these external systems influence daily operations of the OR to make sure that they are meeting compliance and meeting benchmarks when it comes to patient safety and outcomes. When looking at the purpose of the OR, it's simple but very critical. They aim to provide safe, efficient care to all surgical patients across pre-op, intra-op, and post-op phases, such as maintaining sterile techniques, preventing infections, and excellent teamwork to minimize any type of complications. The purpose of the OR directly supports Mercy's missions by advancing compassionate community care and also achieving value-based outcomes. When looking at patients, the OR serves a diverse patient population ranging from pediatrics to geriatric. Common procedures would include orthopedics, general surgery, OBGYNs, cardiothoracic cases, and emergent cases. The patient needs are very clear. They want safe anesthesia and surgical care in a timely manner access, also effective pain control and clear communications. Patients, of course, want to value cultural and language support when needed. Patient satisfaction is closely tied to feeling informed, cared for, and experiencing less complications and faster recovery. The OR ensure that they meet patients' needs through team collaborations, safety protocols, informed consents, patient educations, and continuously quality improvement. Looking at professionals, the team is made up of many unique roles. The surgeons will inform the procedures, anesthesia providers will give the anesthesia, maintain the airways, and monitor hemodynamics. Nurses will coordinate, position the patients, and document. Surgical technologists will prepare instruments and assist the surgeons and patients. Anesthesia techs will assist the anesthesia providers. PACU nurses will ensure safe recovery of patients after anesthesia, and transport the patient or discharge them when it's safe to do so. When looking at processes, we're wanting to focus on anesthesia. So we're gonna start out with pre-op. We're looking at the patient's chart, histories, any type of labs, medications. We'll order any labs, testings, and optimize the patient for surgery. We'll obtain consents, come up with a plan, and communicate with the surgical team and anesthesia team. We'll set up the OR. We'll make sure that we have all the equipment that we needed. That's very case specific and patient specific. We'll have airways, IV supplies, fluids, drugs, and ensure we have everything on hand before having the patient in the OR. We'll start out with inductions. We'll give the medication, secure the airway, watch their vital signs, and treat any abnormal vital signs. Maintenance phase, we'll continuously monitor the patient. We'll change, adjust any type of anesthesia, death. We'll intervene and communicate any changes with the surgical team. On emergence, we'll start weaning everything off safely. We'll reverse any type of medications. We'll watch for the vital signs, make sure they're stable for extubation and transport. We'll take them to PACU. We'll do an SBAR handoff with PACU nurses and highlight any changes during surgery. And now we'll move on to Maribella's part.
In terms of patterns, we see some key metrics and trends. These include timely anesthesia induction, complication rates, and PACU recovery times. Trends show that delays in anesthesia setup can impact efficiency, but structured handoffs and continuous monitoring improve safety. Outcomes highlight the importance of vigilance. Missed or delayed recognition of abnormal vital signs can lead to complications, while proactive monitoring and rapid interventions reduce risk and support faster recovery. Ultimately, the key is that teamwork between anesthesia and OR staff consistently reinforce reliability and patient safety goals. In reference to adhering to the 5P framework from our evaluation, here is each of our proposal ideas with evidence as to why they may provide an opportunity for our microsystem to improve. These include, first of all, implementation of ClearSight non-invasive continuous hemodynamic monitoring device, controlling the adverse effects of hypotension during surgery. Our second quality improvement we've identified is providing safe anesthesia care by evaluating the gastric contents using ultrasound before surgery for patients taking GLP-1 inhibitors. Our third quality improvement is by reducing patient complications by researching adverse effects of scopolamine patch for patients greater than 60 years of age.
Discovers an element of professional improvement, which is important to the 5Ps framework. We want to ask, how often are CRNAs considering the P450 inhibitors and concurrent drug administration? One very common example is the need for frequent redosing of muscle relaxants, particularly in patients on seizure medications. This study here does discuss a new medication called remimazolam in the ways that it bypasses the P450 metabolic system. We thought it would simply be interesting to provide more education or perhaps more discussion about this liver's very important metabolic pathway. Number 5, we would like to improve patient pain and comfort on ketamine's influence on post-operative delirium in patients older than 55. As CRNAs, we of course desire a pain-free experience not only for patient comfort but also to improve hemodynamic stability. But how often are CRNAs following your patients several hours after their anesthetic into their PACU stay to discover the long-term delirious effects of ketamine with anesthesia? PACU nurses often know immediately on their initial assessment when a patient's received ketamine in the OR. Without further ado, we would like to introduce our chosen quality improvement project. We would like to use the Edwards Life Science ClearSight Continuous Blood Pressure Monitor to improve patient outcomes. The nature of the problem is that hypotension exists in the OR. However, we are monitoring our blood pressure every 3 to 5 minutes. This monitor, as you can see to the right, follows patients' blood pressure continuously. It is like an arterial line, but is non-invasive. As you can see, it fits around a patient's finger and mathematically does calculate the patient's continuous systolic and diastolic blood pressure. So back to the nature. The nature of the problem is that intraoperative hypotension, MAP less than 65, places patients at increased risk for acute kidney injury and myocardial infarction. Both would be significant concerns of any anesthetic. However, the utilization of this ClearSight monitor may improve with increased provider confidence. Right now, it's used on occasion and not all the time. However, if we provided providers with a better knowledge base of how to apply this new device, we might see better patient outcomes. The significance is that implementing better hemodynamic awareness amongst providers cuts intraoperative hypotension episodes by 50% in the literature. I think it's important to discuss that this device could potentially replace the standard blood pressure cuff. That was developed in 1896. Yep, that's right. 1896, the blood pressure cuff was invented, and very little has changed in its use since then. I think that is one of the longest lasting devices and patient interventions that has really not been updated for a very long time. We think about all the things in medicine that go through quality improvements, yet the one thing that we are treating every 3 to 5 minutes is still from the 1800s. It's just very interesting to think about. This could be a valuable non-invasive tool rather than a replacement for patients requiring invasive arterial lines. Because it's non-invasive, it can be used broadly amongst patients. And it would provide real-time feedback from hypotensive interventions such as fluids or vasopressors in the operating room. It also does complement other non-invasive modalities such as a flow track monitor, cerebral oximetry, cardiac output, and stroke volume variations. Lastly, CRNAs take great pride in ensuring hemodynamic stability under anesthesia. The nature of what we do, patients are become very vasodilated. We're giving many analgesics. We're under general anesthesia. Hemodynamic stability is the forefront of our jobs. And blood pressure is our main determinant of whether we are going to treat a patient for hypotension. It's just interesting to think about that this is the only non-continuously monitored vital sign. The one thing that we're treating is the one thing that's only monitored every 3 to 5 minutes. We monitor heart rate, heart rhythm, pulse ox, and tidal CO2 continuously. Yet blood pressure is every 3 to 5 minutes. It's just an interesting thing to think about. And we do feel that this product definitely follows suit with the national quality aims. The quadruple aim for improvement would like for hospitals to improve professional satisfaction. Well, of course, if you have continuous blood pressure monitoring, that would certainly reduce provider stress and create a level of satisfaction amongst CRNAs. Patient experience. This is a pain-free alternative to an invasive monitor. An invasive arterial line monitor can often be a very, very uncomfortable experience for patients. Population health, this is huge. This non-invasive arterial line broadens patient access to continuous monitoring who may otherwise not qualify for an invasive line, which is huge. To offer patients a better anesthetic is something definitely to be looked into and worthwhile. Reduce costs. We do need to evaluate the alternative costs of this device, but it is worth noting that it is used in replacement to invasive monitoring, which invasive arterial lines do require a fair amount of medical device usage. And there, I'm sure there are studies that compare the cost of these two, an invasive versus non-invasive hemodynamic monitors. The Institute of Medicine's, its 6 domains for healthcare quality. Firstly, patient safety. This is non-invasive. It eliminates the risk of thrombosis, the infection, bleeding. It provides definitely better hemodynamic monitoring than every 3 to 5 minutes of randomized blood pressures. It is effective. There are studies that prove that it matches arterial line monitoring, particularly in non-cardiac cases. It's patient-centered, It's comfortable and non-traumatic. Timeliness, you have real-time monitoring of your blood pressure, and therefore you have real-time intervention of that blood pressure. Then with provider knowledge, there's minimal complication delays as well. Usually with arterial lines, if you're not able to get it on the first stick, you need to obtain an ultrasound, you need to obtain several more pieces of equipment. This could really delay delays within the healthcare system. Lastly, it's efficient. It eliminates the standard arterial line supply costs like we discussed. It is a higher cost than the blood pressure cuff, yet the benefits of this are substantial and they're definitely worth looking into. And finally, it's equitable. It has broad applicability to many different subpopulations of people, and it's applicable to patients that would otherwise solely be monitored every 3 to 5 minutes, which is huge. That's a great advantage. So we would like you to just take a look at our references, and we are so excited about this project. We can't wait to get going, and we just are thankful that you took the time to listen and watch our PowerPoint, and we will see you soon. Thank you.